Hi, everyone. We're going to look at the integumentary system some today. This is the second half of Unit 2. And the integumentary system, that is our skin, but it also includes our accessory organs as well, or accessory structures, I would call them. So what is the skin? Like we mentioned, it's called the integument, and it's about 16% of our body weight. And it is exposed to the external environment, so it is our first line of defense. So here you can see we've got the cutaneous membrane we're going to talk about, the subcutaneous layer, or the hypodermis, that's underneath. And then we have several accessory structures. So various glands, hair follicles, we'll see things like our nails, all of those are accessory structures. So the functions of our skin, they're going to protect underlying tissues and organs against impact, abrasion, fluid loss, and chemical attack. We're going to see the excretion of salt, water, and organic wastes, so things like our sweat. It's going to help maintain a normal body temperature through either insulation or evaporative cooling as needed. It's going to produce melanin, which protects underlying tissues from UV radiation. Melanin's that pigment that gives you a tan. It's going to produce keratin that's going to protect against abrasion and serve as a water repellent. Skin synthesizes vitamin D3, and it's specifically a steroid. Can you think of which category of organic macromolecules steroids are? Hope you thought about them being a lipid. And these steroids are going to be converted to calcitriol, and this is a hormone that's really important for our calcium metabolism. The integumentary system stores lipids in our adipocytes and the dermis and in adipose tissue in the subcutaneous layer, and it detects touch, pressure, pain, and temperature, and relays that information to the nervous system. So it's more than just protects the body. So you'll see that this does overlap quite a bit with lab. So remember that there's two main parts. There's your cutaneous membrane, and then there's your accessory structures. Your hypodermis here, or your subcutaneous layer, is not technically part of the skin, but it does play a role in this area because you've got some vessels going through it. And your cutaneous membrane has two parts, your epidermis and your dermis. And then your dermis has both the papillary layer and the reticular layer. And then we'll go through some of these accessory structures as well as we go through. So let's start at the epidermis. This is part of the cutaneous membrane. It's the most superficial part. And the dominant cell type is keratinocytes. Some people will call them keratinocytes, but keratinocytes. This tissue is stratified, and it's squamous tissue on the surface, and it's keratinized, so it's waterproof. We don't want to be absorbing a bunch of water when we're in the shower. You have these epidermal ridges that are going to interdigitate with your dermal papillae, and that's what's going to help your epidermis stay attached to your dermis and not just flake off. These are separated. When these are separated, you might have a blister with some fluid between them. So remember, stratified, keratinized squamous cells in our epidermis. You can have thick skin or you can have thin skin. So thin skin is most of our body. It only has 4 layers. So strata is another word for the layer, and it's thin by measurement. So you can see you've got your epidermis and then your dermis. In thick skin, your epidermis has 5 strata, or 5 layers, and this is really just found in the palms of your hands and the soles of your feet, much thicker in actuality. Here you can also see your dermal papilla and your epidermal ridge as they are approaching the dermis. So our layers of our skin, the mnemonic I have always used, can Lucy get some bagels? That goes from superficial to deep. The stratum lucidum is only in thick skin. And then your stratum granulosum is an easy one to recognize. It is this darker layer. Usually can be below the stratum corneum and the stratum lucidum. And then below the granulosum is the stratum spinosum and basale. So once you find that granulosum, you know the two that are above and you know the two that are below. So we'll start at the bottom with our stratum basale. It's attached by hemidesmosomes to the basement membrane of the skin. And the most common cell type there are basal cells. And these are stem cells that are actively dividing. And here you've got your Merkel cells, which provide for touch, sensation. Your tactile discs are there. So you can get some sensation in those deeper layers of the skin. So the stratum spinosum has about 8 to 10 layers of your keratinocytes, and these cells are linked by desmosomes. This is where our Langerhans cells or dendritic cells are found, and this is a special type of cell that lives in this area and helps fight skin cancer and microorganisms, so trying to protect us in this area. So here is our stratum spinosum, right below the stratum granulosum. And so here's your stratum granulosum. It's that little bit darker, 3 to 5 layers of your keratinocytes, and it's making the proteins keratin and keratohyalin or keratinohyalin. It's not dividing anymore. All our dividing has stopped. The cells are starting to kind of become thin, and the membranes are becoming a little less permeable at this stage. Our next stage is our stratum lucidum, and it's a clear layer only found in thick skin. It's really dense. The cells are flat. They have no more organelles, and things are dead and dehydrating. And they dehydrate so that they can form our stratum corneum. This is a bigger layer. So we've got 15 to 30 layers of cells, and these are dead and filled with keratin. They're linked by desmosomes, and they take about 7 to 10 days to reach the surface from the stratum basale. So we're always migrating from deep to more superficial, and then they'll hang on to the surface here for about 2 weeks before they're shed. Whenever I would see pets that had skin infections, I'd look at them under the microscope and I'd send the pet home with a minimum of 3 weeks of antibiotics. And if you wonder why 3 weeks, well, it's going to take 7 to 10 days to get the layer from the stratum basale to the stratum corneum. And then that layer is going to take 2 weeks before it falls off. So it's going to take 3 weeks to get rid of every infected skin cell. And so if we stop the antibiotics early, either the body will develop resistance to it, or we'll have some layers that bacteria didn't get completely treated. We've got skin that's not clear. Infection comes right back. So using that timeline to help guide our treatments. And then the stratum corneum is also a location of insensible perspiration. So it's not completely waterproof, it's water resistant. So you will have some fluid loss, not through like a gland or a duct, but just between those cells. And it's not much, it's about 500 milliliters a day. So like half of the fluid bags you might see on TV. So take a minute, look at the question. You can pause if you need to. So which layer of the epidermis divides to make new cells? I hope you recognize that it is the stratum basale. So answer B. So skin color is genetically determined, and it's related to both pigments and dermal circulation. So the primary pigments are melanin, and melanin is produced by melanocytes in the stratum basale and then dispersed via melanosomes. And it can be brown, black, or yellowish in color. So if you look here, here is our basement membrane, here is our stratum basale, and here is a melanocyte. It's got these little tentacles or extensions that reach between the cells, and then you've got little vesicles that are breaking off. These are melanosomes that are taking the melanin to the individual cells. So the more active the melanocytes, they're going to make more pigment, and that's going to lead to darker skin. Note that if you have someone who's an albino or has albinism, they're still going to have melanocytes, but they're not going to produce the pigment. And so without the pigment, the skin is going to be like completely white. If you don't have a ton of pigment, you'll still get this like red pink tinge because of hemoglobin. So your blood, oh, we got the cats in the background, so you may see them running around. I apologize. But you may see some pink tinge or some red tinge from that hemoglobin in your blood. If you have a lot of capillary beds, you're going to see a change in coloration. Skin that's more keratinized will likely have less coloration. So think about like a callus where it may be a little lighter than the surrounding skin. UV exposure is going to make your melanocytes more active. We talked about albinism, where you still have melanocytes, but they don't make any pigment. And then you also have cyanosis. And this is when the blood is not well oxygenated. So instead of the skin appearing like pink or red, it's going to have this like blue, muddy color, almost purple. Keratin is another pigment that is in the skin, and it comes from orange vegetables, hence the name has carrot in it. And it can accumulate in epidermal cells and some fatty tissues. So there are cases where people have eaten way too many carrots, and they will have the keratin accumulate and they will turn an orange color. So some carrots are good. Excess of most things is not good. Skin cancer, so any cancer is this abnormal or uncontrolled cell division, and it is the most common type of cancer, and very common here in Florida because of our UV exposure. So we see types like basal cell carcinoma or squamous cell carcinoma. These are most likely due to UV exposure. These don't metastasize. If you can remove it, you've got a pretty good prognosis, though, if it's really extensive, you may have to have some reconstruction. So, this would be more likely to be one of those more benign or non-metastatic tumors. Malignant melanoma is very aggressive, and it can metastasize through the lymph system to other organs. If it's caught prior to spread, the prognosis is good, but after it spreads, it can be challenging to treat and is a cause of death, and is seen in people that are young. So I have two friends out of my friends and their husbands that I went to college with. So we'll say that's 18 people. I've had two already under 40 that have had very concerning melanomas that had to be extensively removed. They were caught before they metastasized, but again, I'm not that old yet, and so it's a big deal to keep up with your sunscreen and your skin checks, because if you wait, you may get to where it's not treatable. So underneath the epidermis, we've got the dermis, and it's the second part of the cutaneous membrane. It is connective tissue, and there are two layers. So the papillary dermis is this more superficial layer made of loose areolar connective tissue, and your reticular layer is this lower layer that's made of dense and irregular connective tissue. And they have collagen and elastic fibers. These fibers can be damaged by UV radiation and aging, which is what causes fine lines and wrinkles, because you don't have as many elastic fibers, so everything gets a little more saggy. The number one thing you can do to prevent wrinkles is wear your sunscreen every day, all day, so you don't have to worry about that UV exposure. So your subcutaneous layer is known as your hypodermis. It is not officially part of the skin. It separates the skin from underlying structures and allows for independent movement of the skin. So that's what allows me with my arm to like jiggle my skin around. It's not directly attached to the muscle or bone underneath because it's got the hypodermis layer. And there are a lot of adipocytes here for energy storage. And their largest deposits in women we see in the breasts, the buttocks, the hips, and the thighs. And in the men, we see in the neck, the arm, the lower back, and the buttocks. Abdominal fat or central adiposity is linked to cardiovascular disease. So if you have excessive abdominal fat, it is something that your physician will want to keep an eye on because there is a link between those two. And the hypodermis is a common injection site. Since there's no vital organs and there's not a lot of blood vessels, you don't have to worry about poking something that's really significant. In animals, there's even more space in that hypodermis, so between your dermis and what's underneath, so that subcutaneous layer. And what we will sometimes do is, especially in the back where there's a lot, we will put fluids in. So IV fluids, but not going in a vein, going under the skin, and kind of extend that hypodermis out with the fluids so that the body can absorb them over time. And maybe that animal doesn't have to stay in the hospital or doesn't have to have a catheter placed. And then we give vaccines in that area as well. So you've got a couple of touch receptors in the skin for sensation. So in your epidermis, you have your tactile discs, which help with texture, and your free nerve endings that are going to help with touch and pressure. And then in the dermis, you've got your tactile or Meissner's corpuscles. So here we've got our Meissner's corpuscles. They are for fine touch and vibration. They're in the papillary layer. You've got your lamella or Pacinian corpuscles. These are deeper in the dermis and in the hypodermis, and they're going to help with deep pressure and vibration. And then you've got your bulbous corpuscles, also known as your Ruffini corpuscles, that are in the reticular layer, so much deeper, and they're going to help with pressure and stretching of the skin. So we've talked about a couple of these in lab, so keep those in mind as you study the different receptors of the skin. And then we've got tension lines. So tension lines are formed specifically by how the collagen and elastic fibers are arranged. And they're all organized in parallel bundles to resist the applied forces in normal movement. So to kind of make sure that your skin isn't splitting and that your skin is strong in the ways it needs to be strong. But this is super significant because when you are doing surgery in a patient, you want to cut with the lines to reduce the scarring and to reduce pulling. So if you cut, for example, on this person, if I were to cut straight down perpendicular to these tension lines, each one of these lines is going to be strongly pulling on the skin, and it's actually going to pull my whole incision apart so that it's going to have a lot more scarring. It's going to be less likely to hold the sutures. You're going to have more problems. If I wanted to make an incision here, I would cut with the tension line. You're getting less pull on either side. It's more likely to hold. And when I was doing surgery, if I had a mass to move at a funny spot on or a mass to remove at a funny spot on a patient, so like up here is always kind of a weird spot, the axillary area in dogs and cats, I would get the book out every time and look at my skin tension lines and decide which way I was going to make my incision, because I want to go with those lines to reduce scarring. So we'll talk a little bit about a clinical correlation in burns. These result from exposure to heat, to friction. I don't know if anyone's ever had a rug burn, but those can be pretty painful. Radiation, a big problem with people undergoing radiation therapy, though, is becoming less of a problem as technology develops. You can see burns with electrical shock or from strong chemical agents. In animals, we used to see burns on the tongue from dogs that chewed electrical cords. So you could see just a straight burn across the tongue and the roof of the mouth. Cats may be a little less likely. I think I saw one once, but it was mostly dogs that got excited about those electrical cords. And if large areas of skin are damaged, we can really compromise its function and its homeostasis. So you're going to have compromised function that can affect its protection of the organs. but also its ability to prevent fluid loss. So you will have dehydration, you will have electrolyte imbalance that can cause kidney impairment or circulatory shock. You will have trouble maintaining temperature because you've got this large open area where the blood is very near the surface, and so it's losing heat. And then again, you're not going to be protected from infection. So the severity is going to be categorized based on the depth of the burn, which is where you have a pin test, and the total area affected, which is called the rule of nines. So we classify by the depth of the burn. So a first-degree burn is only partial thickness. It's just the epidermis. So you got it right here. An example might be sunburn. You'll have some erythema, which means redness. You'll have some inflammation, but it's just involving the epidermis. If you have a second-degree burn, this is known as a partial thickness burn too, but we've got the epidermis and some dermis as well. And here you're going to start seeing blistering, you're going to start seeing pain, you're going to start seeing swelling. There is a risk of infection. It'll take 1 to 2 weeks to heal. And then if we get to third-degree burns, we've got the epidermis and the whole dermis is compromised. It's into the hypodermis. It is a full-thickness burn, and the pain receptors are destroyed. So the pin test, what they'll do is they'll poke it with a pin, and surprisingly enough, the goal is for the burn to hurt. If the burn hurts, then that tells us, okay, it's only a first-degree or second-degree burn. If you poke with a pin and there is no response at all, or you see this horrific burn and the patient tells you that it doesn't hurt, that is very concerning because that's a third-degree full thickness burn. And treatment for that is going to usually require skin grafting. If you burn more than 20% of your body surface, you're going to have critical homeostatic properties affected. So we really do need that skin. And at that stage, you're starting to talk about skin grafting. This was an issue in our veterinary patients under anesthesia. Things have changed now, but it used to be that to keep pets warm under anesthesia, they would put them on a heating pad. And so occasionally you would have a pet with really thin hair, and this is back in like the 80s, and they would get a big burn on their side. And because they were under anesthesia, they wouldn't know that they were getting burned. They didn't have any pain response. And so there was no stimulus for them to move. So now we actually have what's called the bear hugger, and it actually blows warm air around them so that there's no chance of part of the body being on something too hot for too long. But some of those patients would require skin grafts from their degree of burning. The rule of nines also helps you estimate the percentage of skin burned to know a little bit about the prognosis. So remember, we said if you have more than 20% of the skin surface affected with third-degree burns, you're going to have critical homeostatic properties affected. So in the human, each leg is about 9%. Each upper limb is about 9%, the head is 9%, and the trunk is 36%. So that's a quick thing. You know, you're in the ER, you see someone comes in that burn, you see it's the right leg and the right arm. You're going to immediately say, okay, this is 18% of the body surface. If there's any more burns, that are third degree and really serious, we got to take action. A little bit different for children. So the rule of nine doesn't quite work as well for children, though you can just see it's mostly that the head is a higher percentage. And then what do we do for burns? Well, number one, we want to replace the fluids and the electrolytes. We want to support the cardiovascular system, make sure the patient isn't dehydrated. We need to have lots of nutrients to meet those increased metabolic demands for thermoregulation. So we're really having to work hard to keep the body warm, and then to meet the demands for healing, because it's going to take a lot of energy to make those new cells. We want to prevent infections. So that means cleaning and covering the burns, changing dressings, applying antibiotics, and then assist with tissue repair. So there are different kinds of skin grafts. You can have a split thickness graft or a full thickness, depending on how much skin is damaged, on the location, on the type of skin you have for a donor site. An autograft, so auto meaning self, is the best and is preferred. In the future, we're hoping that we can take skin cells from a person and grow them like in a petri dish, so that you don't have to donate big pieces of tissue, but time and money is a problem. You can get an allograft that would come from a cadaver. And that is an effective way if you're donating your body, and you're an organ donor, there is the chance that you could offer great skin for someone with a burn. And then you can also do a xenograft, which is where you'd put animal skin there. It's going to help reduce fluid loss. It's going to help with thermoregulation. It's going to help prevent infection, but it's only temporary from rejection. My story of skin grafts, and this is for all of our dental students, because I saw we had a few, is I had some gum recession in my gums and they needed to do a graft. So granted, this is not skin, this is mucous membrane, but it can help you remember. So initially, they did a graft from cells that were grown in the lab, that not necessarily from a cadaver, but from like a cell line in the lab. It was like a little sheet of tissue paper that looked like cells. And so they put that in my lower lip, and it did not go well. My body did not like it, and it got really red and really painful. And after a couple of months, it was all gone because my body recognized it as, this is not yours, it's foreign. So I then had to go back in, and I had an autograft done where they took a piece of tissue from the top of my mouth. They kind of like sliced it off, and then placed it down at the bottom, which worked great and was so much less painful because my body recognized it as the preferred tissue for healing. So autograft is always the best. And then here is an example of prognosis. So if you have 80% of the skin burned, you're only going to have a 50% chance of recovering in a young, healthy patient. So burns are really serious besides just the pain that's involved. So question for you, we've got 3 patients that are coming into our clinic. Which burn are we going to expedite up the chain and triage as the most serious? Take a minute, look at your answer, and choose your answer. And I hope that you chose the one that is not painful, because that means it's a full thickness burn and it's going to be the most serious. So let's look at some accessory structures of the skin. We've looked at our cutaneous membrane, and now we're going to look at the accessory structures. Those are our hair follicles, our exocrine glands, and our nails. Have some for you. Oh no. Well, quick pause. Wonder where those are. So first, let's look at our hair follicles. These are derived from epithelial columns. And we're going to see that these produce the hairs that protect the skull. Hair follicles produce hairs that provide delicate touch sensation. There are no hairs on our palms or our soles of our feet, and there are two types of hairs. So there are terminal hairs that are more coarse, and then vellus hairs that are much more delicate. So terminal hairs, you would think like hairs in your axilla or hairs in the pubic area, versus your vellus hairs are those really fine hairs on like your face that people are microblading. Think about those with vellus hairs. So here we have the sebaceous gland around the hair that's going to produce secretions to coat the hair and the skin surface. We've got the shaft of the hair. We've got the root of the hair that anchors the hair into the skin. And then our root hair plexus, which is our sensory nerves that surround the base of the hair follicle. And we've got our erector pili muscle that is attached to the hair follicle and is going to pull the hair erect when it contracts, and that's also going to help release the sebum at that stage. So hopefully this looks a little familiar from lab to you. Here we're looking a little bit more at the hair structure. So we've got our cuticle, that's the most outer layer, and these are produced at the edge of the matrix. They're going to form the surface of the hair, and they are thin, hard keratin. We've got our cortex, which is thicker layers of hard keratin. And then we've got our medulla, where there's a layer of daughter cells formed at the center of the matrix, and it's soft, flexible keratin. The hair matrix itself is the part down here that's actively dividing, and it's got contact with the hair papilla. So here we've got our actively dividing cells, we've got our hair papilla, and then the hair bulb is the expanded base of the hair follicle, and it surrounds the hair papilla, which has those connective tissue and the blood vessels and the nerves. And so if we look at a cross section of the hair, you've got your cuticle on the outside, then your cortex, then your medulla of your hair. If you think about like all the commercials for conditioner, they're always talking about how it smooths the cuticle so your hair will look extra shiny. And then if we look at the hair follicle itself, we've got this outside connective tissue sheath. We've got what's known as the glassy membrane. We've got the external root sheath and the internal root sheath. So you can see those here, as you can see that connective tissue on this image, and then the other layers that are part of the hair follicle. So hair growth goes through a couple of phases. The active phase will last 2 to 5 years, and the hair will grow about 0.33 millimeters per day. And then from the active phase, you're going to go into regression and transition. And then that's going to move through the resting phase, where the hair loses its attachment to the follicle. It's going to become a club hair. And then when that follicle reactivates, it's going to get shed because something's going to push it out, and we're going to have new formation. And so the follicle is going to reactivate, and we're going to see replacement hair grow. And variations in growth rate and duration of the cycle result in different lengths of uncut hair. So, you know, your hair didn't start at every hair at 0. So they would all be the same length, but some follicles grow faster, some slower, and they're all on a little bit of a different cycle. So we're going to talk about exocrine glands. These glands are derived from epithelial columns. So glands are part of our epithelial tissue. We've got endocrine glands that are going to secrete into the blood. We'll talk about those later, but exocrine glands are going to secrete into ducts, and we've got our sweat glands. So our eccrine or merocrine glands are kind of the sweat that we see that's thin, clear. And then we've got the apocrine sweat glands in places like the inguinal area or the pubic area and the axillary area that are going to be a little thicker and may have more odor. And these sweat glands help with thermoregulation and secretion. And then you've got your sebaceous gland. These are holocrine glands. That's going to lubricate the epidermis. So it's called a holocrine gland because our cells are going to burst to release their secretion. This is the sebaceous glands. So we're seeing here's where a piece of hair would be. Here is all of our hair follicle. Here is that sebaceous gland that's going to release its material into the follicle where it would kind of travel up the hair, which is why your scalp gets oily before anything else, because you've got where that's where your sebaceous gland is leaving its material. And then you've also got sebaceous follicles that just directly secrete sebum onto the skin surface. Sebum is made of triglycerides, cholesterol, protein, and electrolytes, and it's going to lubricate the hair shaft and help prevent infection as it's antimicrobial. You've got your apocrine or apocrine sweat glands. Again, these are in your axilla, your nipples, your pubic region that make this sticky, milky, cloudy secretion that smells when it's broken down by bacteria, highly influenced by hormones, which is why if you go into a male dorm, there's a different odor than a female dorm. And some of that is just related to hormonal changes. And this includes our mammary glands as well. So you can see here, you've got your apocrine gland cells, you've got your lumen, you've got some connective tissue, and then here's some myoepithelial cells that may play a role in release of that material. And then here is our eccrine or our merocrine sweat glands. These are found on our palms and the soles of our feet, but they're also found across the body. And you're going to have water secretion with salts, helps with thermoregulation and excretion of wastes. So here's those eccrine sweat glands with a little bit of the lumen there as well. And we've got our nails. So nails are just a thickening of the epidermis, and they're going to protect the fingers and toes. So protect those tips. They are really just keratinized epidermal cells. So cells that have that waterproof material, and then the nail body is cells that have died. So if we look at this image up, oh no, we're not ready for that yet. If we look at the image up here, you've got the nail bed, which the nail body rests on. The nail body is those dead folds, and then you've got your lateral nail folds that kind of come over the edge. This underlying blood vessel is going to give the nail its pink color, and you have the lunula down here. That's that little crescent. A lunula comes from luna or lunar, like the moon, looks like a little moon. Your eponchium is going to be your cuticle. And then you've got your proximal nail fold as well. So if we look here, here is that cuticle, that eponchium. Here is your nail root where things are going to grow from. And here's that proximal nail fold. And then the area right under the nail at the free end that's growing is your hyponchium. So onchi is the prefix for things having to do with nails. And finally, some clinical correlations for our skin, specifically aging, hormones, and repair. So a couple of things that happen as skin ages. We have fewer melanocytes, so we're going to be more sensitive to sun exposure. The skin is drier because we're having less sebaceous glandular secretion, and the epidermis is thinner. We're going to have less of an immune response. We're going to have a thinner dermis. We're going to perspire less. This is a big one here in Florida. Unfortunately, every so often you hear about a nursing home that has lost its air conditioning, or after a hurricane, they're at risk of heat stroke. And you'll have fatalities in that because the elderly can't perspire to help maintain their body temperature. They have less control. Your fewer elastic fibers in your dermis are going to lead to sagging and wrinkling. You have a reduced blood supply in your skin. And so that's going to make the skin feel cooler. But the brain doesn't really know why that is. And so it's going to stimulate thermoreceptors and say, like, hey, the skin feels cooler, something's going on, you better warm us up, which is why if you go with your grandma, I think of my grandma, she is always cold. And yes, a portion of that is she doesn't have a lot of muscle, but a portion is her skin has a reduced blood supply. So that thermo regulatory center is always turned on. She always thinks she's cold. Right now, she wants to have 6 blankets, and she still says she's cold. And we keep telling her to wear a sweater, and we're making progress on the sweater. So, but you can think of my grandma with her 6 blankets because of her skin and her muscle tissue. You've got fewer active hair follicles. You've got altered hair and fat distribution as well when aging happens. You also have weakened connections between your dermis and epidermis, so you're more likely to have like problems with wounds, or you brush up against something and then the skin just kind of peels off. You're going to have less vitamin D3 production, and you're going to have fewer of the Langerhans cells that would be helping with infections. So you want to know for sure, what are some of the changes that happen in aging with the skin? Hormones impact the skin. So the skin is tied to all other body systems. So growth hormone stimulates fibroblasts and collagen synthesis. Glucocorticoids, that's steroids. So it's going to loosen the connections between your keratinocytes and reduce the effectiveness of the epidermis as a barrier to infection. Thyroid hormone is going to maintain normal blood flow to this subpapillary plexus. Sex hormones will stimulate cell division. They'll increase epidermal thickness and accelerate wound repair. You've got growth factors that are going to stimulate cell growth and division. And then you've got epidermal growth factor, which is going to promote cell division. It's going to accelerate keratin production. It's going to stimulate repair, and it's going to stimulate the activity of these glands. So there are multiple hormones that affect the skin. Glucocorticoids in animals, I think less so in people, because people have more trouble taking them long term, but in animals, people that give their animals steroids long term will actually have thin skin, and you can start to like see the blood vessels through it, and it starts to look like wet tissue paper, because you're loosening those connections and the epidermis is not being as effective as a barrier. And then hormones in the skin. This is a big one. And we're going to talk about vitamin D3. So vitamin D3 is called cholecalciferol. That's its official name. So D3 is cholecalciferol, and it's required to make calcitriol. Calcitriol is an important hormone for homeostasis of our calcium levels. And so in the stratum spinosum and the stratum basale, these cells can convert a specific steroid into cholecalciferol using UV light. And so you can see our sunlight changes that steroid compound into cholecalciferol in the epidermis. And you can get some from your food as well. It's going to go through the liver, have an intermediate product, and then in the kidney, it's eventually going to produce calcitriol. Rickets is a lack of deposited calcium salts in the bone because you don't have enough cholecalciferol. And so this is a problem where there's not enough vitamin D3 that's absorbed. And so you're going to see really flexible, poorly mineralized bones. And that is a big problem. And so if that's the case, you want to have more time outside or have some fortified milk. If you see the milk that has additional vitamin D3, that can be helpful. The cholecalciferol in elderly, so our vitamin D3 in the elderly decreases by 75%. This means that they're not able to absorb calcium and phosphorus as well through the intestinal tract. They're going to have less calcium in the body, and their body is going to start pulling calcium out of the bones and lead to decreased bone density. So this is why we see more fractures in the elderly, is because of that part of that decreased cholecalciferol. Interesting side note, cholecalciferol is used in one of the rat poisons in rat baits. So there's a couple of different rat baits, but this one is particularly traumatic because what it does is it creates this extra calcitriol and stimulates calcium absorption and will actually start to mineralize the tissues and turn the tissues into bone where they can't function. So this is one, if you have animals that are outside or dogs, make sure that they can't get into any bait. Make sure it is doubly sealed up. Don't use it unless you have to. Be aware if your neighbor is using it. And if your pet ever gets into any kind of rat bait, get them checked out right away, because in dogs, it is possible to have that because it is a toxicosis. And humans can get too much vitamin D, but it takes a lot to get too much. This is also why lots of doctors suggest vitamin D3 supplementations. They'll test to see if your levels are low because we want to make sure that we've got enough calcium to keep our bones nice and strong. And then our last little clinical correlation is skin repair. So there's 4 phases. We want to know those 4 phases. We've got the inflammatory phase, where mast cells will trigger an inflammatory response because of this injury, and we've got some bleeding going on there. We're going to have the migratory phase. So at this phase, we have a scab that forms, and then our macrophages are going to be removing debris. And we've got cell division that's going to migrate along the edge and replace the missing cells, and we're forming granulation tissue. I love granulation tissue. It doesn't have pain receptors in it, and it is resistant to infection. So it's always a great day when you have some granulation tissue, because that means things are on the mend. There are some animals like horses that have a problem with excessive granulation tissue, though, and it has the funny name proud flesh, and it can become a problem because it just is too much, and if you remove it, it just keeps forming more and more. It's just not appropriately regulated. So we've had the inflammatory phase, the migratory phase, and we're going to have the proliferation phase. So in the deeper portions, the clot's going to dissolve. Fibroblasts are going to make new collagen fibers and ground substance. And then finally, we have the scarring phase, where there is scar tissue formation. Keloids are this particular facet of skin repair, oftentimes genetic, where when the skin repairs, you get this excessive scar tissue formation that can be raised and really prominent. Some cultures will use that as kind of a way of marking the skin, so similar to tattooing. But if you're a surgeon or working with surgeons, or even for yourself and for your family, if you know someone that has keloids, make sure that they're letting their doctor know, because we want to work to limit the amount of scarring so you don't have an elevated scar at an area unless you really want one. So there's a little bit of additional information. Oh no, I've got a question for you. So where can the body obtain cholecalciferol from? You can pause the video to take a minute and look. And I hope you said A, it's made when a steroid is converted to a new compound with UV light. So there's a couple of more things you'll want to keep track of on your own, and that's the different kinds of microscopes. We've talked about that a little bit in lab, but some study suggestions. You may want to make some sorting cards. So have, for like your tissue types, for your skin layers, especially for the skin layers, you would have your term on one card and a definition on the other. And then you might try and put them, you'd match the definition and the term and put them in order. So you kind of get double duty using your sorting cards. And then there's additional information on the microscope, kind of goes over what we went in lab, but spend a little bit of time peeking at it on your own so that you're familiar with it. This is in Canvas, so you've got access to that.